So.
Hey guys, what's going on? It's Jay Campbell and Nelson Vergel with the Real Truth Men's Health Webcast. We are excited today to be joined by Dr. Justin Saya, Jason Bruce, and also Jim Brown. Monica and I flew in on Monday to Tampa. We are in the Defy headquarters in Tampa as we speak. We're kind of a little bit makeshift. We're in Justin's office right now, so a bunch of us here, we couldn't get bandwidth in the conference room, so we're in Justin's office. But anyway, how are you doing today, Nelson?
Doing great. It's a crazy time, but I'm excited. This is a very hot topic today. So you may want to set Dr. Saya a little bit higher on the screen.
Okay, I can do that.
There you go.
Better?
Perfecto. Yeah.
Okay.
How are you doing, Dr. Saya? Nice to see you again. I haven't seen you in a while.
How are you?
Doing good. So we today we're covering a very, I would say, a really general topic that can go in many directions. Is the management of fatigue. We're not only going to be talking about men, but also women. We all have this problem, as everybody knows. Most of us are running around busier than ever. World is becoming more competitive. We tend to be sleeping less, it seems. Parents are more and more, involved with their kids' schooling. So people are a little bit run out, and I get a lot of questions on excelmail.com and on the Facebook groups about fatigue and how to manage it, especially from guys that have started testosterone replacement therapy and they still feel run down. So we're very happy to have Dr. Saya and from defymedical.com. They've been very generous in working as one of the sponsors on excelmail.com. So why don't we start, Dr. Saya? We have different topics and different ways to address this. Why don't we start talking about the basic, most important thing that is involved with energy levels and fatigue, like the sleep quality. I'm going to talk a little bit about circadian rhythm and what that means. But why don't you start on what you've seen with your patients when it comes to, sleep apnea, sleep quality, and then we move on into other topics.
Yeah. So you're right. This is a massive topic, a huge topic. I mean, we could probably actually talk all day about it. And we're certainly probably going to miss, certain factors that contribute to fatigue because there's just so many. I mean, if you type in fatigue in any diagnosis assistance program or algorithm for physicians, you'll come up with probably about 1,000 different potential causes. So directly to your first question about sleep, that's a very common sense one, and it's a very often overlooked one. I think in our busy lives, across the world, but especially in this country, we get so busy with our business, with our family life, that we tend to take sleep for granted. And sleep is I consider sleep like a vital nutrient to the body. It's on par with air and water. We simply can't survive without sleep. We'll die. So that shows you how vital it is. And not just quantity of sleep, but quality of sleep. And that's where things like circadian rhythm come into play. That's where things like sleep apnea can affect your quality of sleep. I mean, a patient who has sleep apnea, they'll think they're sleeping for 6 or 7 hours a night, but they're not. Their brain is never shutting off. Their oxygen levels are low all night. Their brain's constantly awake and stimulated, and they're never really getting their deep, restful sleep. So in effect, they may be, unconscious for 6 or 7 hours, but they're really getting zero productive sleep on their body and causes fatigue, just like poor sleep for any reason would cause. So a huge topic, and sleep is certainly a very overlooked and common cause of fatigue.
And how does somebody address, for instance, first of all, how does somebody talk to their doctor about whether or not they have sleep apnea, and what are the signs and symptoms, and the diagnosis and treatment?
Okay, so signs and symptoms, fatigue being a big one, and particularly we call it daytime somnolence. So if you sleep well at night, when you wake up in the morning, you should generally feel rested. You should feel well rested if you've had a good night's sleep. If you wake up in the morning consistently, morning after morning, feeling fatigued, groggy, and that persists throughout the day, that can be a sign of many different things, but sleep apnea is indeed one of them. Certain clues that we look for as a physician to the possibility of sleep apnea: if a patient comes in and they have an hematocrit level, measure of red blood cells that's on the upper end of the range, or perhaps even above range. There's other factors can cause that, including what we're all aware of, like testosterone levels. But if they come in and those levels are on the upper end of the range and they don't live at a high altitude, they're not a smoker, that could be an indicator, a possible red flag for sleep apnea, especially if it's in conjunction with those other symptoms like excessive fatigue during the day. So, we check CBC panel, hematocrit. I ask patients about snoring. There's a strong correlation between snoring and sleep apnea, especially with guys. Body habitus, the heavier you are, the thicker your neck is, certain things like that anatomically can contribute and make you more prone to sleep apnea. So we go over a discussion about various different things of that nature.
Yeah, and I've also seen actually thin people having sleep apnea. So it runs, in some of them, runs in the family. It's almost like a genetic issue. Because I was surprised to see one of the clients I have, coaching clients, basically a BMI of 24 and a neck size of 15 and still having sleep apnea. So it's not, obviously the thicker your neck is and the heavier you are, obviously the risk factors increase when it comes to that. And what happens, and what happens also with many, and I'm one of them, I had to go for 2 sleep studies, and we'll talk about sleep studies, in which they hook you up to all these wires, and it's definitely not a fun nighttime. You spend you sleep on this lab, basically they look like hotels, but it's not a natural sleep. So it's very difficult for me. It was very difficult to sleep while being measured and my oxygen levels and all that. So I had to go again and was able to sleep for at least 3 hours and was detected to have mild sleep apnea, and tried a CPAP machine with no success. I tried it for 2 weeks and I could not handle it. So it's a very frustrating thing for some people. My partner, Tim, he uses a CPAP and he's happy and it works great for him. He doesn't toss and turn. So it's one of those things I have to say for some people that get the diagnosis and treatment, the CPAP, and they're coming up with fancier and better CPAP machines. So I'm following that field because I may need one eventually. So, but you've seen some of your guys, your patients are on CPAP too, right?
And if they truly need it and they use it consistently, which it's an adjustment, to get used to sleeping with something on your face. But if they truly have sleep apnea and they use it and it's calibrated right, oftentimes those guys, it's an amazing transformation in those guys. They feel a lot better. They have better energy. Their blood pressure goes down. Even they often experience weight loss from that. And I correlate that with probably their cortisol levels. So it's very important if a patient truly does have sleep apnea to get that addressed, not only for quality of life, but also health maintenance reasons.
Yeah, and we forget that during the sleep cycle, we have not only obviously increased melatonin, growth hormone output, cortisol increases obviously at the end of the, by 5, 6, 7 in the morning. Even testosterone is basically, for those that are not using obviously testosterone replacement, increases at night. The nighttime erections that happen while we're dreaming actually are regenerating the penile tissue. If you're not sleeping well, you don't have that too. So can you give a few tips, and I have a few of my own, obviously, when it comes to what we call sleep hygiene, the different things that people need to be aware of, like light exposure, etc.
That's a good one, and that's something that there's a whole area of science, dedicated to sleep hygiene and what we should and shouldn't be doing. Back before electricity and artificial light, what happened was our circadian rhythm ruled our sleep-wake cycle. When the sun went down at night, it got dark outside, our melatonin levels go up, and we go to sleep. Now we have artificial light with electricity. We have laptops, we have our iPhone, we have our big screen TV in our bedroom. And when it gets dark, we turn the lights on. So we tend to, just by virtue of that alone, we tend to throw off our circadian rhythm naturally. So, the recommendation is typically that we limit our exposure later in day, especially for an hour or two before bed, to artificial light. they've got all kinds of, they even have apps on the iPhone and Android now that filter out certain wavelengths of light, like the blue light, whether they work or not. But it's raising awareness, I think, to that particular topic. And that's important. Other things, like making sure that you're not doing anything that's activating your brain before bed. You don't get in an argument with someone. You're not playing a very active video game before bed. Things like that. You want to relax. You want to allow your body and your mind, very importantly, to wind down before sleep.
Yeah, you want to decrease that dopamine level, before you actually, some of us are working late on the computer and, looking at the screen, the lighting. It's challenging.
I have to stay off Excel Melody at night. Keeps me up.
So we are, I tend to, sometimes I hear friends say, you should take your own advice. You will be so much better off. But it's a struggle. I tell people, so make sure your room is dark. Try to get at least 6 to 8 hours. And some people need more, some people need less. Try to keep your room a little cooler than usual. Body temperature you tend to sleep better when there's although some people may argue against that.
Nelson, real quick. One thing too, a book that I recently read is they recommend that you don't charge any of your technology in your sleeping room.
Yeah.
So if you have your phone by your bed and you're charging it, you're going to disturb your sleep, because obviously if somebody texts you or it vibrates or whatever, and obviously we all have networks now that are global. So people are going to be, sending messages and buzzing it at inopportune times. So they say you shouldn't actually have any technology in your sleeping room.
Yeah, I put my phone on a sleep mode. I didn't used to bring it to the bedroom until recently, and obviously I have personal reasons, because I have a older, obviously a father-in-law that may or may need help in the middle of the night. So some of us have to have a phone close by. So I just put it on sleep mode, where I only get phone calls on my iPhone from selected numbers that I can get. Actually, it will ring. So it's easy to do it on the settings. So some of us, unfortunately, have to have access to having our phones next to us, but nothing really wakes me up unless he calls me in the middle of the night. So that's obviously a challenge that some of us have, because we're reading out of iPhones and iPads, our books, even Kindle. The new Kindle has some bright light too. So, but anyways, let's move on to the next topic. Let's talk about hormones. Let's start with, obviously we can cover go from testosterone to thyroid to adrenal insufficiency issues, which are obviously tied to sleep quality. So when it comes to testosterone replacement, what I'm seeing is a lot of guys have high expectations. And I don't blame them, because obviously there's so much marketing out there for testosterone replacement. And we've seen obviously the benefits when it comes to libido and quality of life. But some of them feel disappointed within a few weeks of starting, when they don't feel like their energy is normalized. So what do you have those patients? What do you tell them? What else do you look for?
Yeah, good question. So you're absolutely right. Testosterone isn't the end-all be-all to cure fatigue for all patients. And the reason for that is testosterone doesn't exist in a vacuum. It's not the only hormone at play when it comes to fatigue. Fatigue is so broad that there are many other hormones that can contribute. And you mentioned the thyroid and the adrenals, and those are big ones. So patients that don't necessarily notice what they would expect in regards to their energy levels when they go on testosterone therapy, very, very often it's because they have another concurrent hormonal abnormality or deficiency. And the thyroid and the adrenals they're probably tied for 1 and 1A following testosterone deficiency when it comes to those. So that's a clue. Patients that don't do well in the first few months on testosterone therapy when it comes to energy, that's a clue that you want to look deeper at the other hormones, which we typically do anyways.
Yeah, like thyroid, what kind of testing do you do?
So, we have to balance, because we're a cash clinic, so patients pay cash for the labs. If everyone had unlimited funds, I would shotgun approach it. I'd order a full thyroid panel on every single patient. I'd order the TSH, the free T3, the free T4, reverse T3, and the antibodies, and that'd be easy. We'd catch everyone.
Yeah.
But because we're a cash clinic, I have to balance, patient finances with need for tests. So initially, we still use the TSH as a basic screening test. We all know it's not perfect. We know it doesn't pick up everyone, but it gives clues. And to a trained provider, when a provider picks up on clues with that TSH and then they ask the patient about symptoms, that provides enough of the foundation to then go ahead and do further testing. And that way you're saving patients that might not need that testing money, but you're selecting the patients who need that testing for the testing to try to identify the problem. And that's when we order things like the free T3, free T4, reverse T3, and potentially the antibodies if we suspect autoimmune.
And when it comes to symptoms, what? Weight gain, heat intolerance, or cold intolerance, I guess that's what we should say.
Yeah, weight gain, in fact, when a patient's in office, which, we treat telemedicine across the country, but when a patient's actually in office, you can tell a lot just by shaking the patient's hand if they have cold hands. Either they're nervous or they might have a thyroid or adrenal issue.
Yeah.
But, fatigue is a big one. Weight gain is a big one. Cold intolerance, which, folks sometimes don't know what that means. It means that you get cold easier than other people. Your hands and feet are cold. If you check your body temperature throughout the day, your body temperature can be below normal. That's something that a lot of folks can do at home very easily and get some clues about their thyroid function. Dry skin is another sign. Hair thinning or hair loss, particularly if you have a bad case of hypothyroidism, you can start losing the outer 1/3 of your eyebrows. So there's certain symptoms like that that are clues, and the more of those symptoms you have together, the more likely it is that you may have hypothyroidism.
When it comes to adrenals, and that's a more controversial topic, since there doesn't seem to be an agreement on what even the use of the term adrenal fatigue is controversial in the medical field. We tend to use more adrenal insufficiency. And how do we test for that, and whether or not using saliva versus blood testing, etc., and how you actually diagnose and talk to people about their adrenals and how to improve their adrenal health. What do you have to say about that?
So, first of all, to the adrenal fatigue versus insufficiency, to me, it's tomato. Doesn't really matter what you call it. It's the same thing. The adrenals aren't working the way they should be. They're not producing enough hormone. So that's, to me, it's kind of a pointless debate on that. But I don't think anyone would disagree with the fact that certain people have adrenal issues where their adrenals don't produce enough hormone. And that's what we're focusing on. A lot of the symptoms can very strongly correlate with those low thyroid symptoms. So sometimes, and it's not coincidental that oftentimes adrenal issues, they're present with concurrent thyroid issues together. So, teasing those out is really a matter of doing the appropriate blood testing to determine if it's thyroid alone or if it's thyroid plus adrenal. DHEA sulfate is a good test. That gives you clues as to the adrenal function. Cortisol is another important test. Unfortunately, often cortisol is checked in the blood and it's just a morning cortisol level. That's not really sufficient because cortisol levels have a pattern throughout the day, typically. They should have a pattern throughout the day. And in order to really gauge the levels and the pattern, you need to check it 4 times in one day. Now, obviously, people don't want to go to the lab and get their blood drawn 4 times in one day. So for that, we do saliva testing. You have a kit from the lab. You take a saliva sample at 4 times in the morning, lunchtime, early evening, and before bed. That shows your levels of cortisol, and then very importantly, your pattern of cortisol. Should be highest in the morning and decline throughout the day, lowest at night. So that gives clues. That gives clues to the adrenal function as well. If you need to go much deeper than that, you can even do things like checking an ACTH level, adrenal corticotropin hormone. That's above and beyond. That's for the difficult cases. There's even things like an ACTH stimulation test, which is usually more in an endocrinologist's office for that. But those are the tests that we use with regards to the treatment. Similar to the thyroid and with testosterone, we watch the numbers, but we're really treating symptoms. That's the key, is we want to make the patient feel better while watching the numbers somewhat secondarily.
Yeah, I tell a lot of the guys on Excel Mode to protect their adrenals, and what I mean with that is obviously stress can affect adrenal health, high caffeine consumption, lack of good sleep. So basically all we're doing in modern life basically keeps straining the adrenals. Some people are drinking Red Bull and then drinking a cup of coffee and re-challenging the adrenals even more. So there's no wonder why usually cortisol is higher in the morning, then it goes down, it peaks a little bit again in the afternoons. And obviously our body tends to, when we're trying to sleep, it goes down and then it regenerates back up to normal. So no wonder some people are suppressed.
The tough thing, when you're talking about, the tough thing is that poor sleep or lack of sleep stresses your adrenals, but also when you're getting good sleep is when your adrenals recover. So if you're getting poor sleep and you're stressing your adrenals and your adrenals are struggling already, they're not recovering, it becomes a vicious cycle to where it just gets worse and worse. Unless you intervene and go on either a treatment and or ideally go on a treatment and address the causative factors, which you mentioned, sleep, stress, stimulants like caffeine. So it's really a lifestyle approach in addition to medications if needed.
Yeah. And going back to testosterone, what do you have to say about testosterone effect on sleep apnea, testosterone replacement? And that's another controversial. There are opinions on both sides of the fence when it comes to whether or not testosterone replacement can worsen baseline sleep apnea or not.
Yeah. So I've seen, there's two types of sleep apnea, by the way, and this is important to have a distinction. There's peripheral obstructive sleep apnea, which is by far the most common. That's what people think of when you're snoring, your airway closes up and you stop breathing. There's also central sleep apnea, where your brain doesn't really send the signals to the diaphragm to breathe. That's different. That may, in fact, from my understanding, that is more likely to be exacerbated by testosterone therapy, as opposed to the obstructive sleep apnea. In fact, in my experience with patients, some of the benefits of testosterone, which often is weight loss, particularly fat loss, not necessarily weight loss, but fat loss. Patients lose fat, they lower their body fat percentage, they get a smaller neck sometimes, and oftentimes the net result from that is if they had sleep apnea, it actually improves, if not goes away.
Yeah, that's a good point. That's a good point. And back to another side effect of testosterone that I think may affect stamina, energy levels, is people feeling winded because of excessive water retention, edema, and that's another tricky topic to talk about. Can you add your experience on that subject?
Yeah, so it's not uncommon for guys to experience and every water retention is different to every guy. Some guys, if they think they look a little puffy, it's water retention. Some guys get true edema where they take their socks off and they have a ring around their ankle. That's water retention. There's no arguing that. But early in therapy, sometimes there can be an increase in aldosterone, which affects your sodium.
I think you broke up. Say that again.
Early in therapy, there's often an increase in aldosterone, which affects your sodium retention. And water follows sodium. So if you're retaining more sodium, you retain more water. That can cause further retention. That usually evens itself out over the first few months of treatment. It can be debated if elevated estrogen levels can cause some further retention. Some folks who are sensitive, it will. Some folks who are not sensitive, it won't. But those are things that are correctable throughout the course of treatment. So that's not something that if a patient experiences that on TRT, it means that their TRT is not working for them. It just means they have to have a closer look at their labs and they might need some adjustment.
Yeah, but when it comes to like a peripheral, like edema or water retention, like especially in the ankles, do you sometimes get concerned about cardiovascular health? Any blood flow issues? Let's talk a little bit about cardiovascular health and workup for some patients that really seem not to respond to anything when it comes to fatigue.
Yeah. So, first of all, and this can be like a public service announcement for anybody listening, the swelling of lower extremities, if anybody ever has swelling on one side and not the other, they need to go to the ER or their doctor. They need to get evaluated. That's a huge sign of a possible blood clot, a DVT. If that breaks off, goes to the lungs, not good. So if they have swelling on one side more than the other, that's a red flag, go to the doctor. If they have swelling equally on both sides, and it's what we call pitting edema, where you push in on it and it pits. It leaves an indentation for a few seconds and then goes back to normal. That's usually extracellular fluid that's in the extracellular space, which means you're probably retaining some fluid. One possible cause of that is congestive heart failure. Not very common, in our patient population, and in fact, if guys have that, often they have those symptoms prior to even considering TRT. So that's something that guys will come in with, not likely something that's going to be exacerbated or present after starting TRT. But if there's ever any concern of any cardiac issues, including congestive heart failure, Patients can go to their primary doc, get an EKG done. That will show if there's any signs of ischemia or stress on the heart. They can ultimately get an echocardiogram done. That can show if they have high blood pressure, a history of high blood pressure, they can have enlargement of the right side or the left side of the heart. Enlargement of the left side of the heart can cause fluid in the lungs, pulmonary edema. Enlargement of the right side of the heart can cause peripheral edema, like in the legs. So the only way to really tell that if there's thickening or enlargement of the heart is with an echocardiogram, an ultrasound of the heart.
Good. Another question I get is because in my world, I come obviously a lot, from the HIV research side of things, and many medications, or not many, the older medications we used to take affected the way mitochondria, the energy factories of the cell, work. So that actually is proven by research in our world. Can we talk a little bit about any potential, not only health, lifestyle changes, but supplementation, nutrients that can probably, that's another controversial topic, improve ATP energy production out of mitochondria that may be affected due to illness, medications, age, et cetera, et cetera. Is that something you're willing to expand on?
Yeah, absolutely. So, as you said, the mitochondria are the power factory of every cell in the body. They run the biochemical processes that create energy in your body. And the human body is just simply that. It's tissue, cells, and a whole bunch of biochemical reactions that go on. So in order for those reactions to proceed, your body needs the reagents for those reactions, which means the ingredients for those reactions. So, the B vitamins, the B complex of vitamins, they play important roles in biochemical processes in the body. If patients are deficient in those, their metabolism and their power factory isn't going to run well. Some folks take supplements like NADPH, ADP, which is a precursor to ATP, adenosine triphosphate, things like that. There's mixed data that I've read on things like that. That some folks report improvements in energy, various different things. D-ribose, isn't that what the APS is?
Yep.
D-ribose is something that actually is offered as an injectable supplement that some folks use. In fact, some of our patients. And we've had overall, on balance, fairly positive results with that when it comes to things like energy. So there's various things patients can do when it comes to getting down to that cellular level, but it basically comes down to just making sure that you're getting everything your body needs, especially the B vitamins, and you have the reagents that your body needs for those reactions.
Yeah, and let's talk a little bit about the injectable supplements that you guys sometimes you prescribe. Can you expand on that?
Yeah, so we talked about the D-ribose. A very popular one that we offer, slightly different, is called Lipo-C. That's basically a modified and upgraded version of a B vitamin injection. So it includes B vitamins, including B12, which most patients are aware of B12. Most weight loss clinics get that. Helps support, just like I said, those metabolic processes in the body. So it supports metabolism, energy, potentially weight loss. The lipo part of it are what are called lipotropics. L-carnitine, MIC, which is methionine, inositol, and choline. Natural things already in the body. They're not medications, but you're just enhancing the levels. They help your body to more efficiently use fat for energy. The body doesn't typically want to use fat for energy. It wants to use carbohydrates, glucose. But if you can more efficiently burn fat, instead of holding on to it and storing it, that often helps people with energy and things like weight loss as well. I can talk one other one that's not necessarily along the lines of metabolism, but it's probably our second most popular one, is Triamino. That's a mixture of 3 aminos, ornithine, arginine, citrulline. They work synergistically to help boost nitric oxide in your body. Nitric oxide is the main vasodilator. It opens up your blood vessels, improves blood flow. A lot of guys are familiar with nitric oxide boosters as a pre-workout supplement. So a lot of guys will use it in that way as a pre-workout to dilate blood vessels, improve blood flow, flush the lactic acid out better, have a better recovery, more stamina. Some guys even use it at night. The arginine at night can sometimes help boost growth hormone production. So we were talking about that during the sleep.
Yeah, I've had good results with Lipo-C injected intramuscularly. Had some issues with subcutaneous, reactions there, and energy level there for me. I take coenzyme Q10 high doses. I really feel a difference. Carnitine, 1,000 milligrams, and SAMI, which is a precursor of glutathione, in the body. That seems to be, and some studies show a little bit of a mood elevation effect. So there's some good research there out there. I think there's a lot of abuse also in the supplement industry, selling stimulants that actually fully drain your adrenals even more. And that's my concern. A lot of guys going to the gym. Well, obviously I drink my espresso before going to the gym, but I'm seeing a lot more high stimulant doses for even working out, and they're wondering why they can't sleep or why they're so wired, after the fact. Obviously, they probably have a good workout, although their heart rate may be a little too high for their own good. So that's another thing worth mentioning.
Yeah, I went to my local supplement store not long ago, and I was looking at their pre-workout supplements, and I was looking at the ingredient list because I wanted one specifically that did not have caffeine in it. And they didn't have one that didn't have caffeine. They ordered it.
Is Jasen and Jim around there, or are we hearing?
They're here.
Yeah, hold on, everybody. Everybody's here.
How come you guys are hiding?
They're hiding.
Jim, haven't met. How you doing? Yeah, it's like, we're monopolizing this whole thing. I'm tired of speaking, tired of talking, so you guys take over. Hey, Jasen. Hey, I only see half of your face. You may want to move the. We always seeing right now is Dr. Saya's diplomas. So, Jasen, can you?
Actually, I had one question. I'm in the background, trying to not hide behind Justin, but back to the fatigue, from the adrenal fatigue. Like, I think a lot of guys, and Nelson, we have a number of questions, and we'll get to them in a second. But a lot of guys always talk about, they're overstimulated from the thermogenic supplements and all the different things they're taking. What's a great way to go cold turkey off of those things and maybe possibly add some adaptogens or something to re-stimulate?
Label awareness is the first thing I used to teach when I worked at the supplement stores. A lot of times these stimulants are hidden in like white willow bark instead of caffeine.
Right.
There's different herbal blends that actually have caffeine alkaloids in them. So you have to learn to read the label and avoid proprietary blends. When you see a pre-workout drink that has a proprietary blend of maybe 15 different ingredients, but it doesn't give the specific strengths for those ingredients, that's where I'd be leery and maybe assume that most of that strength is in the caffeine. So it's always better to buy individual ingredients. Buy your L-arginine by itself, buy your L-carnitine by itself, and put it together.
I'm having a little trouble hearing you well, Jasen.
Sorry about that. He's got to speak
that
into the
fancy
microphone.
microphone, man. That's a fancy microphone.
Yeah, he's got to speak into the microphone.
Can you repeat that again? I think some of us may not have gotten that whole.
I was saying one of the things that'll help is having label awareness, and it's something I used to teach when I worked at a supplement store. But a lot of times caffeine is hidden under other ingredients like white willow bark. And when you have these proprietary blends, like a pre-workout drink that has 15 different ingredients, but it doesn't give the specific strengths for the ingredients, it's safe to assume that the majority of that strength is going to be some sort of stimulant, and that's what's getting the bang for the buck. You want to avoid those synthetic stimulants. You want to buy your supplements individually. So buy your L-arginine, your L-citrulline by itself, and combine them together. That way, you know that you're only eating the ingredients that you intend on taking.
And what talking a little bit about the injectables against nutrients, since you're pretty much an expert on the subject. Can you add anything to what Dr. Saya said?
Well, somebody might ask why inject vitamins and amino acids. That's a great question. Obviously, some of us understand when you take supplements orally, vitamins and amino acids, you only absorb a very small percentage. And some people with poor gut metabolism might not absorb any at all. So when you inject a nutrient versus consuming it orally, you absorb 100%. You get a little bit more bioavailability. And with some nutrients, you get a drug-like effect. So take magnesium, for example. If you infuse or inject a high dose of magnesium, it can have a similar effect as a muscle relaxant. So if you're in a lot of pain, you have muscle tension, you can dose with injectable magnesium and get a similar effect as a muscle relaxer that would have more side effects. So you can induce drug-like effects or more pronounced effects with an injectable nutrient versus maybe taking it orally.
And these are not available over the counter, right? Injectables, you need a prescription.
All injectables should come from a U.S. licensed compounding pharmacy that has a sterility license and it needs a prescription. All pharmacies require a prescription to send any kind of supplement or injectable out.
So can any compounding pharmacy make injectable nutrients?
No, only a compounding pharmacy that follows 797 compliance and has a 797 approval to compound injectable medications, nutrients. So you want to look for a pharmacy that specializes in injectable medications, and there's quite a few out there. And if your doctor doesn't know about the stuff that's available, you can actually have that pharmacy send your physician an order form so that that doctor can order the injectable nutrients.
Okay, good. I have another question for Dr. Saya that somebody just sent me before we actually move on to questions that are being posted right now. When it comes to depression, okay, the treatment of depression or the addressing the underlying conditions, you know, or situations that can worsen depression. Can you tell us a little bit about your experience on testosterone thyroid treatment? Do you have patients that even after adjusting all those levels are still finding themselves depressed due to unknown reasons? Some people have stress or hopefully some drama in their lives, obviously, and they're not coping well. But let's talk a little about depression, since that is so tied to low energy levels. In your experience, the use of antidepressants, for instance, even in those that have been optimized when it comes to their hormones, is that what's your position on that? I know there's a lot of people against the use of antidepressants. I'm one of them that actually believes that they have a proper use in certain people. And obviously, I read even a paper that most people's patients switch antidepressants 6 times before they find the one that doesn't cause as many side effects or, you know, actually works for them. So it's not an easy task either. So can you add anything on depression and management of depression?
Yeah. And we've talked about this a little bit, you know, you and I, and through Excel Mail conversation. The appropriate use of antidepressants, that's key. Use the word appropriate. And the problem I have is that I think a lot of doctors, just through, you know, sheer lack of knowledge or just lack of you know, willpower, they don't use it appropriately. First of all, and I don't want to get on the soapbox too much, but young patients coming in, even older, any age patients coming in with depressive symptoms, especially if they're in conjunction with other symptoms that can be depression related, can be other things. I mean, every patient should have a hormone check, I think, because I see so many patients coming into me that are already on antidepressants because they went to their primary care doctor with some of those symptoms. And we come to find out that they have very low hormone levels, whether it be thyroid, adrenal, testosterone, or all the above. Now, who's to say that those low hormone levels may have been the cause of their depression in the first place? And now they're on this antidepressant, which almost invariably their primary doctor is going to view it as a long-term treatment, you know, basically a lifelong treatment. I've had patients tell me their doctor said you're going to be on it for life because it's working for you. Well, maybe it's working, but maybe they just went through a tough time in their life and now they're not depressed anymore, they're better. So that's one of my pet peeves when it comes to antidepressants. But when used appropriately, they are helpful. I view them, for my patients, I use it very occasionally. I view them as a short-term kind of a Band-Aid treatment, a bridge type of treatment, just because they are so prone to some side effects, you know, and no matter which one you use, there's some that have less side effects than others, but every single one, just like every single medication, has side effects. And it's generally something that you want to try to get to the root cause of the problem. You know, the antidepressants, SSRIs, they basically just falsely elevate serotonin levels in the synapse. They don't do anything to really get to the root cause of, okay, if they have low serotonin, why do they? Maybe they need some of the precursors of serotonin. Maybe some tryptophan, some melatonin might help them. Maybe they just need to sleep better. So I'm not against them, but I'm a proponent of very appropriate and cautious use of them and temporary use for most folks.
Yeah. Some guys complain about orgasmic dysfunction or low libido on them, or they feel numb. They feel better because they're not, you know, suffering as much, but at the same time, they don't feel much about anything, including arousal, you know.
In fact, they're prescribed sometimes for patients with premature ejaculation for exactly that reason.
For them to last a little longer. And now that we're talking about medication side effects, something else, at least in the Excel mail, the aging members, and I'm one of them, I'm 50, almost 58. The use of, many people are on blood pressure medications. some of the unfortunate ones are on statins, but mostly the blood pressure medications. I'm also seeing a lot of complaints on fatigue. Can you expand a little bit on blood pressure?
Yep, absolutely. Now, blood pressure is another one that very often, the drug companies don't want you to know this, but probably about 3/4 of all high blood pressure patients can be cured with weight loss. Simply just weight loss, not a drug. But when it comes to blood pressure medications, like I said, with all medications are side effects. Common ones with the blood pressure medications are erectile issues and fatigue, and then sometimes even, ironically, weight gain, which then will ironically increase blood pressure further. So it becomes a struggle. I've even seen guys coming in on 3rd and 4th line blood pressure treatments. I had a guy the other day come in on propranolol, 80 milligrams, a really high dose, and that's a non-specific beta blocker. Tons of side effects to that at that high of a dose. And I asked them, did they try other blood pressure meds before that? They didn't try anything. They didn't try a diuretic. They didn't try an ACE inhibitor like lisinopril, which generally speaking, those are better tolerated than the beta blockers. So, it just comes down to, just like the antidepressants, oftentimes it's a knee-jerk reaction by the doctor to throw patients on medications. Oftentimes the patient isn't even aware of some of the side effects that they're getting themselves into. And then once they're on the medication, again, back to the beta blocker, sometimes you can't get off of those quickly. You come off, you have rebound hypertension from it. So it's just, education, knowledge for patients, and knowing that oftentimes you want to stick to that fundamental of trying to get to the root cause and not necessarily jumping on the first medication that your doctor throws in.
How about, what's your opinion on, for those of us that sometimes may not be able to get to sleep fast enough, the use of medications like Ambien or Sonata, or they're coming up with a new one every few months. But Ambien really, Zolpidem is the leader of, I guess, in this area.
Yeah. So there's a place for them again, just like there's a place for benzodiazepines for some patients. The problem is, I think it's highly overprescribed for folks. It's often prescribed as the first line treatment. It's prescribed before the doctor even talks to them about circadian rhythm, about doing things at night that keep them up. It just comes in, I have insomnia, okay, here you go, Ambien. The problem with that is that it's habit forming. Patients become dependent psychologically on it and physically, to where when they use it regularly, they actually start to need it for sleep. And then they're somewhat trapped at that point. And so I very rarely prescribe it, only when needed. And by when needed, what I mean there is when everything else fails. When we try the lifestyle things, doesn't work. We try supplements like melatonin, tryptophan, GABA, taurine, theanine, magnesium, all kinds of natural stuff that you can try before resorting to things like an Ambien or the Nesta that can be had at home.
I think that's one of the problems we're seeing right now is the overprescribing of the benzos, the sleep medications, the Z drugs. And I think what's happening is that it's actually exaggerating the problem of poor sleep, because what a lot of doctors don't understand, and especially the patients don't understand, is when you take these drugs, benzodiazepines, Z drugs, things like that, you're actually becoming dependent. Your brain becomes dependent on them, almost like when you take hormones, your body stops making those hormones due to negative feedback. When you take these drugs that pass the blood-brain barrier, your body stops making the neurotransmitter that drug is mimicking. So, for example, GABA is what the Z drugs like Ambien or benzodiazepines interact with. And I can share a personal story, and which is why I understand what's going on with these, and able to help a lot of patients. When I got out of service, I was given Klonopin for anxiety, and that's kind of the standard of care when you're getting out of the military for some. I was on the Klonopin for about 2 years straight to help me sleep. I didn't really know what the effects were. Decided one day to come off because it stopped helping me sleep. So I actually literally let myself run out, came off cold turkey, ended up in the ER for about a week. And it took about 7 months for me to regain sleep, so liquid withdrawals. And I realized at that point that I would have been better off just dealing with anxiety insomnia rather than taking a drug that's causing me a year worth of side effects afterwards to get back to normal. And if people understood what these things are doing to their brains and their biochemistry and their hormone and in their brain, I think that they would be a little bit more resistant when their doctor tries to feed them those medications.
Yeah, and I've seen actually in following that side of research very closely, and really obsessed with circadian rhythm dysfunction. That's a new term And we're seeing a lot of data on ambient use and decreased memory or loss of memory. They're hypnotic agents, so that's my concern long term. I've used it long term. I'm actually considering getting off of it slowly. That's not going to be an easy task. You actually have talked to you about it, about cutting the dose slowly, even going through a compounding pharmacy and coming up with a liquid formulation to cut down from the 10 milligram down to hopefully 1 and then 0. And that's my goal. So I still struggle with some nights where I'm tired because I'm a night person. I do like the night. I'm not a morning person. I tend to still have to, especially when I'm traveling, take the Ambien. So it's a concern that some of us have. We've been taking these drugs and we want to get off of them, but we're afraid to crash, and we have a job to do, you know.
And it's a legitimate fear because out of any drug that you withdraw from, you can actually die from benzodiazepines, C drugs, and alcohol. So you have that risk there. In addition to the fact that you're going to deal with insomnia, you know, there's always, when you go up, you got to come down. So you take the medication out, you sleep, you're going to go through a period where you can't sleep and you come off the medication. And that is the most maddening, aside from the emotional ups and downs that you experience from those kind of medications. On top of that, having 3-4 nights, even up to a week with 0 sleep will drive anybody mad. And that's why you have a high rate of relapse with those medications. And these patients a month later wonder why they're not better. They go see their doctor puts them back on Ambien or Xanax, and they're on it for life at that point.
So what are your thoughts? I mean, I know you're not a clinician, but you do have a lot of experience on the subject. When somebody's thinking about talking to a doctor about weaning themselves off,
educate yourself, because a lot of the doctors, just like with all hormones, they're not educated on how to take you off the drug and how to put you on the drug. So understanding what's going to happen, and if you understand what's going to happen, it's not going to be scary when it does happen. You have to have time. There's nothing that can cure a withdrawal coming off those medications other than time. You can taper, and that's going to help mitigate some of the symptoms and lower the risk of serious side effects. You can take comfort meds, getting your hormones checked using melatonin, keeping away from caffeine. But you have to understand that it's going to be a 3 to 6 month period, even up to a year if you've been using those medications for a long time, where you're not going to feel right. You're going to start with 1 hour of sleep, then 2, and 3, and it's going to take about 6 months or so to get back up to a normal 8 hours. And if you understand what's happening, it becomes less scary and you're less likely to be reactive and get back on another drug to treat the side effects, and you understand why you're experiencing. So there's a lot of good forums out there that go through withdrawal from these different things, and you can learn what's happening and why, how to supplement, how to come off. And then if you bring that education into your doctor, you'll have a better plan of action in coming off those medications.
but when it comes to supplements for sleep, I mean, what are your thoughts on the best, besides melatonin, which is, I take it, I do a sublingual, I chew it, it works pretty well. What other supplements out there?
My favorite combination, especially at the beginning phase of discontinuing the benzodiazepine, is 5-HTP hydroxytryptophan, which is a precursor to serotonin. It has some relaxing and mood-enhancing effects. D-L-phenylalanine, which is a modified version of the amino acid L-phenylalanine. It actually produces natural endorphins. This is highly recommended for patients coming off pain medications or who have lots of inflammation and pain, because it actually mimics or stimulates your natural endorphins, which also are relaxing and help you go into a sleep. Melatonin is the hormone that regulates sleep, so adding that into the mix will help. And then you can do other things depending on your symptoms. For example, if you have muscle tension that prevents you from sleeping, using a magnesium oral supplement or an injectable to help relax the muscles. And usually using a combination of supplements will certainly help improve the sleep.
Do you have a sleep formula, or do you know any compounding pharmacies that do?
No, but you just gave me the idea to work with our compounding pharmacy and make one.
We have Calm.
We do have Calm. You know, I take that back. We have an injectable called Calm that combines magnesium, theanine, GABA, and some other things as well. Although it's not practical to take an injection, you know, every night. So that's something that can be supplemented, and then having an oral supplement to use in the meantime would probably be effective as well.
Jay, you want to add something? It's almost.
I was just saying that the only other thing I would say, one of the sleep adaptogens would be like valerian root. I've used valerian root. I'm not big on melatonin. I get it doesn't do what I would like it to do. You use melatonin. What kind of dosage of melatonin do you use?
It varies from 10.
Yeah, speak up.
It varies from 10 to 20, and I use a supplement that's fast acting. It's higher dose. I've taken breaks and tried to lower
Jim,
that.
can you get closer to? I can't hear you.
Yeah, speak up.
I use melatonin. I have for years, and I use a sublingual version that's fast acting. It's usually in the 10 to 20 milligram or microgram range. I know that's pretty high dose. I also use magnesium, and the combination of those two work really well for me.
Can you hear him?
Yeah. You guys have to speak up a little. How about questions? We only have 5 minutes to the hour. Do you have anybody online right now typing in questions? Can you tell people how to do so?
Yeah, I can do that real quick. So guys, on the right, if you're watching right now, we have like 11 or 12 viewers, I think, or have been on and off. You can type in your questions on the right. There's also some questions on the actual site, and then there's some stuff on Facebook. Do you want to take any of those real quick, Nelson?
Yeah, well, there was a guy asking about, he's tried everything, he's being optimized, and he basically, the only way he can function completely at work, and this is a question for Dr. Saya, is the use of Adrenal, generic Adrenal, and he's been doing so for years and wants to hear about what to do in his case when he's performing okay, but he's definitely had to take Adrenal once or twice a day to not only for focus but mostly for energy. I mean, those are challenging refractory kind of cases where
some folks need Adderall. Some folks really do. He may be one of them. It's tough to say, him saying I'm completely dialed in, I'm completely balanced. It's tough for me to just accept that without seeing numbers and seeing his testosterone, his DHEA, cortisol, maybe even pregnenolone levels, see how some of those far upstream hormones are doing. Thyroid, a complete thyroid panel. Then we can really conclusively say that he's dialed in and he's balanced. And if that's the case, and other things that we've talked about, sleep, he's sleeping well. We didn't even talk about infectious causes of fatigue. That's a whole other group. Epstein, Barr, mono, Lyme disease, just the common flu. Any illness, any inflammation in the body is going to cause fatigue. So there's so many causes, so many rocks to turn over, so to speak, to try to determine the cause. But some folks do need Adderall. They do need it, or they need some other type of stimulant throughout the day if they have true ADHD. So, it's tough to say specifically about knowing the case 100%, knowing the labs, talking to a patient. But I would assume that there's still a lot more rocks that can be turned over for them.
Good. Jay, do you have any final words or questions? I'm
just scanning through these questions real quick here just to see if there's any really good.
I don't want to look at the wall. You're in gym. Can't you move the laptop?
Sorry about that.
There you go.
Sorry, make do here. Sorry about that.
I'm on. By the way, guys, I'm in Houston. These guys are in Tampa, so that's why I'm on a separate screen, telling them I'm bitching about what's wrong and what's not right. So, not a control freak here, but definitely.
So one person asked about pregnenolone and anti-fatigue connection, oral versus transdermal. He said, sorry if it's off topic. And then another guy asked if someone tested negative for sleep apnea but snores excessively, can that still cause an increased rise in hemoglobin and hematocrit? Answers?
All right, so I'll take the first question about pregnenolone or pregnenolone, tomato. So for going back to the adrenal fatigue insufficiency, if a patient's determined to have low DHEA levels, low cortisol, one or the other, progesterone, another downstream hormone from pregnenolone, what I prefer to do first is to give the adrenal glands the building blocks, what they need to try to produce those hormones. So often if they're low in DHEA, I'll supplement the DHEA directly. I do prefer oral DHEA. I find that it does a much better job at sustaining levels for patients, but it has to be appropriately dosed. A lot of folks take over-the-counter supplements. And it's hit or miss. You may be getting a real product, you may not be, and oftentimes the dosage isn't even close to what you think you're getting based on the lab results. So most guys for an oral DHEA need anywhere between 20 to 50 milligrams daily, 50 being on the high end. But what I also often like to do, and this is especially if they're having concurrent issues with lower cortisol, perhaps lower progesterone, is add pregnenolone or pregnenolone into the supplement. Working with the compounding pharmacy, it's very easy to do that because you can have them add that into the same capsule with the DHEA. So they're basically just taking one capsule and getting both hormones. The transdermal versus the oral pregnenolone, a slight difference there. Once again, the oral tends to support levels a little bit better. The only downside with the oral, and this is actually not really a downside, it's a benefit for some patients. It can be somewhat sedating for some patients. It can have somewhat of a GABA type effect. Not for everyone, but for some patients. So for the pregnenolone oral, I always have patients start by taking it at night. Sometimes they'll sleep better. Actually, often they'll sleep better. Some folks won't. Some folks will have what we call a paradoxical reaction, the opposite, where they'll feel like it activates them. So then I have them take it in the morning. So that's the main distinction. You typically don't get that sedative effect or that calming effect with the transdermal pregnenolone for most patients. But that can be a therapeutic effect, especially for anxious type of patients or patients who have difficulty sleeping at night. So that's another thing going to the sleep that we can try.
Yeah.
The second question was about
Hematocrit. He said if he tested negative for sleep apnea, but snores excessively, can that still cause an increase in hemoglobin?
Right. So, testing negative for sleep apnea, that all depends on the quality of the test. It all depends on what lab you go to, how well they ran the test, if you actually slept at night or not. Yeah. I mean, the test is only as good as who's providing it. So that a negative sleep apnea test doesn't necessarily 100% rule you out for sleep apnea. And there's varying degrees. If you snore at night, chances are that you are having some obstruction of the airway. It may not be overt sleep apnea, but you may be experiencing lower oxygen levels at night. And lower oxygen, that's actually the mechanism of how sleep apnea causes a rise in hematocrit. When you're sleeping at night, your oxygen levels are lower than they are during the day. Your body compensates to that by making more red blood cells. Red blood cells bind the oxygen. So when you have lower oxygen, your body makes more of those red blood cells to scavenge up all the oxygen it can get, and you have that hematocrit level go up. Now, there's other factors that can cause hematocrit to be high. Too much iron in your body, too much B12, higher hematocrit, things like that. So, the short answer is a negative sleep apnea test doesn't necessarily rule out sleep apnea, but if you have higher hematocrit, you need to look into the other factors, including, as we all know, testosterone levels. Higher testosterone levels can cause the hematocrit to go up as well. Usually not very much at physiologic levels.
I hear guys feeling a lot better when they donate blood, when they have high hematocrit. They feel better. They're not as winded, as out of breath. Obviously, that's reasonable since a higher hematocrit. And by the way, guys, some guys don't know what hematocrit is. It's actually the proportion of the blood volume made up of red blood cells, and testosterone actually increases the production of red blood cells and obviously the amount of them in the blood, and that makes the blood become a lot more viscous to pump it. So some guys feel either winded or going up the stairs. They find out their hematocrit is over 52, and obviously they need to bring it down by either donating blood, or if they can donate because they're not allowed by a Red Cross exclusion, there are lots of them, a doctor can write an order for what we call therapeutic phlebotomy, which is basically the same as blood donation, but basically they discard your blood since you were not accepted as a clean donor. So, and last but not least, we haven't really. Once again, I'm looking at the wall, guys. Don't want to be looking at the wall. Jesus.
Sorry.
Director, I'm not controlling, by the way, audience.
You're pushing the button and moving the camera around.
You're just protecting the audience from criticizing us. But anyways, HCG has actually, I've added HCG, and people know that I'm an advocate, a strong biases for HCG use with testosterone replacement, not only for those that want to keep fertility going, but sex drive, which we have very little data on that. And also, we're starting to really see more information on the effect of HCG on upstream hormones like progesterone and pregnenolone, which basically shut down in many men when they start testosterone replacement. So that's another area that needs more research, the use of whether or not the use of HCG with testosterone replacement has more benefits beyond improved testicular function and size and fertility. And I think that's something we're going to see more from. I think, Dr. Saya, you're looking into that question yourself.
Working on it.
Yeah, the hot topic.
There's one other good question, I think, and then if you have anything else, Nelson, a guy asked, it's obviously for you, Doc, when is thyroid treatment the next step? And I'll give you, he says, necessary to test cortisol prior to starting, if he has symptoms of low T3, T4, TSH levels, and if cortisol imbalance is present, must it be sorted out prior to treatment?
So, good question. I'm not sure. Did you hear the question? Come through clear.
Okay.
Did you heard the question?
It was a little broken.
So the question is about when is thyroid treatment necessary if T3, T4, and TSH are low, and what was it about cortisol?
If you check it.
Yeah, if the cortisol imbalance is there.
So basically asking about, the interplay between the adrenals, thyroid, which, that's been a recurrent theme. So when is thyroid treatment necessary? When you have a thyroid deficiency. And deficiency, that definition or that cutoff varies from provider to provider. Some do it just like testosterone. If you're below the range, 1 point below, you're deficient. If you're 1 point above, you're not. The more progressive doctors view it more in terms of a spectrum. Where are you in the range? Are you on the low end of the range? Are you symptomatic? And looking at the entire picture. But the direct question as well, I think the question was really getting at the connection between cortisol and should you test the adrenal? Should you test cortisol before jumping on thyroid treatment? I mean, it's a good idea. It's a good idea because, as I said, a lot of times the adrenal issues overlap with thyroid. They occur concurrently together, and a lot of the symptoms overlap. But also, there's a such thing as pooling of your thyroid hormones. Your thyroid hormones floating around in your blood aren't necessarily doing much for you, and that's what you're checking on a blood test. You're checking the free T3, the free T4 in your blood. In order to do things, what we want them to do, increase your metabolism, your body temperature, improve your energy, they need to get into the cells to do that. And if you don't have adequate levels of things like cortisol, or even adequate levels of things like iron in your body, oftentimes those thyroid hormones, even if you have sufficient levels, they can't get into the cells to do their job. So those are cases that are often missed because they're not checked. So, the short answer is yes. If you want to be thorough and you want to make sure that you're doing it 100% comprehensively, it's good to check the adrenals at the same time.
Yeah. I think we missed one issue is glucose management, hypoglycemic episodes during the day, keeping blood sugar. Can you explain that, Josiah? Because it's really a common occurrence where people forget to eat and then they wonder why they're tired too. So, or they're not eating frequently enough, or they're waiting 9 hours before they eat. Although a lot of guys are now into fasting too. So
yeah, we won't get in that whole talk with our, and carb loading and ketogenic diet. But the fact of the matter is that if you go hypoglycemic, low blood sugar, clinically low blood sugar, you're not going to feel well. You're going to be shaky. You're going to have low energy. Your cognitive function, sometimes folks get confused, and you're going to feel that way. So, without getting into the talk about, diets and carb loading, carb restriction, and metformin and all those things, if you go hypoglycemic, you're going to be fatigued during that episode. So that will occur. That's another factor, although a transient factor.
I snack with high fiber. I snack on nuts and there even fruit with peanut butter. I do tend to snack with things that will sustain my blood sugar more readily, not just spike it and bring it down, like sweets and stuff. But snacking every 2 or 3 hours, even if it's either 300 calories but high fiber, even a little bit of good fats, it's definitely not a bad idea to keep energy levels. I think that I suffer from, and I think a lot of us do in this world, is that I sit in front of a computer for hours And I read once that you need to set a timer in your computer, in your iPhone, a self-text message or reminder to get up every 90 minutes and walk, go downstairs to get water, or go, to a bathroom or whatever it is. Walk every 90 minutes, because sitting for many hours can actually obviously decrease your energy levels. So that's just another tip that I've learned.
All the time, a body in motion should stay in motion. So we're not built to sit around all the time.
And in the morning, I wake up, and sometimes I don't get outside, so I have one of those solar lamps where I read the paper and I read my emails exposed to that light too. So I think exploring different things. The data on that is, they say it works in the Nordic countries. People with seasonal depressive symptoms, they tend to expose themselves to sunlight or lamps that mimic sunshine. So there are many other things. I think we're going to be closing and wrapping up this Google Hangout today. We're going to be posting the video. The video is going to be available as soon as it's over on YouTube and on excelmail.com. Jay, you want to say a few words on where people can post more questions for Dr. Saya and for everybody else, and where the information is going to be posted?
Yeah, sure. So it'll be, like you said, it'll be on our YouTube channel, The Real Truth Men's Health Webcast there. And then, of course, it'll be on our Facebook and our Facebook groups, and, of course, on our Facebook pages. Right now, I think, Nelson, you and I are contemplating topics for next month, too. So, feel free for you guys watching this on the rerun to email us, with ideas about topics. But, I'm just really thankful that Dr. Saya took his time today out of his busy schedule to do this. And then also, Jim and Jasen came in. Although you didn't really see Jim and Jasen, they were here in the background.
Well, your setup was not the best today, I have to say.
No, it really wasn't. We actually had a room to do it, but there was no bandwidth. So we made do, as we always do.
I still love you. I think the guys are good. I think everybody's going to be happy. I think we covered a lot of ground in less than 50 minutes. So I'm very happy with the outcome. So
one more thing. You mentioned the sunlight and seasonal affective disorder, right? Where that increases in the winter when we get less sun. I've got the sun beating on me right now, so I'm getting some. But vitamin D3, another very often overlooked, and almost all patients that we check they're relatively low. That can cause fatigue. So that's another thing folks need to be aware of and check it and start supplementing if you need it.
Yeah, well, great. Well, any parting words, Jay, or you want me to?
No, I thought, like you said, I thought we covered a lot of ground. You're right, the setup wasn't great today, technical difficulties, but everything else was good. There was great content. I appreciate Dr. Saya for coming on. Jim, thanks for serious contribution today.
My pleasure.
Thank you.
Jasen?
Thank you, guys.
Awesome. Yeah, it was good, Nelson. It was great information. So we just have to figure out what our next topic is next month. I think you have a doctor, but again, for the guys out there, if you guys have good ideas or interested things that you would like us to talk about, please send it in to us.
All right. Well, thank you very much, and see you next month. Hopefully with another topic. Post them on excelmail.com, and we'll explore it. So thanks a lot, Dr. Saya, Jasen, Jim, and Jay. And we'll talk to you guys soon, okay?
Awesome. Thanks, Nelson. You guys take care.